label, just to see if it's spread or anything like that. So 19.5, I think. I don't know. I have to look again. I don't know. I have 19.4, 19.5. But the staging process is what you'll definitely want to know.
Maybe one of them in the ninth and one of them.
That's what I'm wondering if I break it to. Yeah, that's. I don't know. I'll look online and I'll let y'all know. I can't remember what it is. Now that oh wait, no, ninth edition. I wrote it down. Is on page 378. 10th edition. Yeah. I'll have to look when I get back to my office. I don't know why. 378.
Yeah.
Yeah. Okay. 378. Yeah. But this grading is only good for tumors. You can't use it for leukemia and stuff like that. They grade that a whole different way. But tumors, this is how we tell how aggressive it is. Risk for abnormal cellular regulation. So your population. Do men have more cancers? Do women have more cancer? Is it pretty equal? Really? I mean, maybe some cancers are more prevalent in women, like breast cancer. I mean, they can still get breast cancer, but it's more prevalent in women. But other than that, you may see cancer like testicular, obviously. Things like that we see, but really women and men kind of have that equal. Like we're all at risk for cancer as we age, especially. Smoking, tobacco use, so individual risk. We can't change our age. I wish we could. We can't. But we can definitely try to eliminate carcinogens from our bodies, right? So smoking, alcohol use, infectious agents, viruses. So we kind of talked about some of those viruses a little bit ago. HPV. I don't know if you guys have read. I did my doctoral project was actually on women's health and their dental because a lot of times, especially during pregnancy, we always talk about how important our teeth are, but even just now, even not being pregnant, we should still go to the dentist. And what I've done with my research is now, even in men, they're seeing a lot of more oral cancers. And do you know what it's related to? HPV. So that is really a big reason why they started doing the Gardasil vaccines in men or boys. Genetic risk. Again, we look at like the BRCA screenings and things like that. We see is there an increased risk for family members? Radiation, carcinogens. What kind of carcinogens can you all think of? Stacey kind of talked about like multiple myeloma, like those people working in like oil and things like that.
Petroleum products.
Petroleum. So my grandfather drove trucks his whole life. They think diesel fumes, being around diesel fumes could have caused his sunlight,
The pesticides.
pollutants, the environment, some environmental.
My dad's an electrician, and like half the stuff that he works with, like the putty and stuff, all says like in California this has been known to cause cancer. So
Yeah.
any trade work really, I feel like.
Yeah, they're up. Yeah, huge risk. Nutrition, physical activity. So obviously sedentary lifestyles. We should be more active. Poor nutrition. So they have a reduction in like intake of fruits and vegetables, fresh fruits and vegetables. Obviously, we want to teach people about cleaning them. They need to intake more fiber.
We're talking about pregnancy and teeth. My mother was 19 when she had the first child, and she lost all of her teeth.
Yeah, pregnancy does. Even my dermatologist, when I walked in and he looked at my skin, which I know is bad. I tanned when I was younger and stuff. I don't anymore. But whenever I went, he was like, I was like, oh yeah, I just had my baby. I was excited. And he goes, pregnancy? Because it changes your body, your skin.
Yeah.
And I was like, hey. And so obviously don't tell them you're pregnant.
So then when they're older, you can say, you know what I sacrificed for you?
Yeah, my skin. Yeah, and your teeth, and that, yeah, it does. It affects all those things. So it's really important. Nitrate, so we talked about that with the stomach cancer. Your charred foods, you gotta really watch those. An increase in animal fat, you gotta decrease that. And then red meats again. These are all educational things we can talk to our patients about. Our assessments, our history. Okay, so obviously we want to take a patient's history, always. We want to know their signs and symptoms. We don't just walk in and start pushing them, prodding on them. We want to know, what made them come in. Examination, use the word caution. This is great because some of these things, nagging cough, what do we talk about with a nagging cough? There's two of them.
Irritation. Oh.
Which cancers?
Laryngeal.
Laryngeal, right? So some of those things are here. Indigestion, what's that? I mean, indigestion can actually go with, your stomach and your esophagus, yeah. Obvious change to wart or mole. We don't really talk too much about skin cancers, but that's one thing we always tell our patients. Unusual bleeding. We talked about the cervix, right? A sore that won't heal. And then a change in bowel. So those are all things because our bowel, you remember me saying pancreas, like they may have clay colored stool. But then also with colon cancer, they may actually see a difference there. Diagnostic tests, I think I was on the next page, but actually, hold on. So tell me some different assessments with leukemia. What do you see? What are some signs and symptoms of leukemia? Without looking back, what do we see?
Bruising,
Fever.
What is it?
Fever.
Fever, yep. Infection risk. Bleeding, right? Bruising, the bleeding. Night sweats. Bladder. What may we see? Assessment wise. UTI kind of fact, yeah, like the same feeling of a UTI. If you've ever had a UTI, they're awful. And there are people that deal with those chronically, so definitely be educating them that, because some people have family feel like, oh, I'm fine, I'll just drink a lot of cranberry juice. And you're like, that's cancer risk. Colorectal cancer, so what do we see? Blood and stool, what else? I just said it.
Diarrhea.
Change in
Change in
bowel.
bowel. The caution, change in bowel. Lung, what do we see?
Coughing.
Cough,
Hoarseness.
nagging cough.
Yeah, that nagging cough, that hoarse, it probably will cause you to be hoarse if you're coughing so much. But those are things that, we would notice. And even that pain, they may have just that pain or even breathing. Shortness of breath. So we already kind of said that. So prostate.
Problems urinating.
Hematuria. Yep. And then skin.
Obvious change to wart or mole.
Yeah. So that's all your assessments, and those are things that you may need to know as far as when you're assessing a patient, what alerts you to these things. Again, I always remind people about horses versus zebras. I heard that in my entire master's program. Is they said you want to learn about these things that are awful, but don't automatically think that when you see a patient. Like if I see a UTI, should I automatically think they have cancer? No, that's a zebra. So think about the horses first before we go off on the zebras. Your diagnostics. So your radiographic, these are all different things that they do to see and check a patient for the cancers. You don't need to know them necessarily for the test. It's just a good way to know why they're doing these things. Pathology, they're looking at the cells, trying to figure out what's going on. And then PET scans are really good because they look at the patient and the cancers will light up, and so they'll be able to see if something has metastasized. Primary prevention versus secondary prevention. Please tell me you know what that stuff means. Somebody told me one time that they said it just doesn't make sense on a test because primary or a secondary prevention is it sounded like a prevention and screening not, and I'm like, it is a prevention. So I don't know. I hope you guys understand the difference between primary. So what is a primary prevention?
Eating right, exercising.
Sunscreen. Chemo prevention. So tamoxifen is actually a chemotherapeutic drug. But we can also do it to prevent, because some women that may, be high risk for estrogen type breast cancer, things like that, we can actually do tamoxifen because it blocks the cancer. One thing to know about like tamoxifen is if it blocks, it doesn't block either, blocks the estrogen. So if it blocks estrogen, what kind of side effects do we see? What happens in menopause? We don't have estrogen. Hot flashes. You kind of have those menopausal symptoms. Aspirin, is that chemo prevention? Remember? For the colon, yeah. And then your vaccine, Hep B, Gardasil, things like that. Secondary prevention is your screening. So what screenings do we utilize? Oh, there's all kinds of them. Come on.
Wait, you're in screen?
Mammograms.
Yeah.
Colonoscopies.
Mammograms, your colonoscopies, your prostate exams, things like that. Those are all your
Smear.
screenings. Yes, those are screenings. So you want to definitely know the difference between those. Treatment goals. So I want to go on to the surgery because this is, again, you have to be patient specific. Not all cancers, even if it's the same type of cancer, is going to be treated the same because our bodies may react different to certain, like some people really tolerate chemo, whereas some people get really sick, right? So it just depends on, the patient and what we can do. Surgery. So surgery, you have prophylactic, and I gave you kind of what they are. So it removes at-risk tissue to prevent cancer development. That's prophylactic. So
Is it
either
like a lumpectomy or a
like a mastectomy,
yeah.
if they have the BRCA screening.
before their cancer?
Yes. Yes. So if they have a BRCA positive and they're like, I just want to get rid of them because I don't want, if I can eliminate my risk any way I can, I want to do this. So that's what they do. Diagnostic, they just kind of want to diagnose it. So they take a piece out. Curative, they remove it. So like I said, with the Mohs therapy that they do, I don't even know, it's like Mohs, MOH. But the dermatology, so that whole thing is basically curative because they can remove it. They can keep removing it until they get all the cancer out. Palliative, we are focusing on quality of life. Okay, that is a surgery that we're doing just to maybe just make them more comfortable. Yeah. Second look, a repeat exam after treatment. So a lot of times patients, especially with like cervical cancer, they can treat it and we don't have to do anything else with it. We can get rid of it all and they don't have to lose all their organs and stuff. What they may do is go back in and they reevaluate it after 6 months or 12 months and they just keep watch on it. Reconstructive surgery, so we're enhancing an appearance. We think about like some women that may have mastectomies due to breast cancers. They may have implants just to make them feel more feminine. And then we have cancer control. So this is a case if a patient may have, let's say, stomach cancer, okay, but they can't remove everything because, we just want to make them a little bit more comfortable. Doesn't mean that, they'll pass or anything. It just makes them, like, better, like maybe the treatment will work if we can remove some of the tumor and then treat the rest of it with radiation, or something like that. Makes it easier to treat. Again, with any surgeries, you really have to assess the patient for their body image because a lot of patients can go through depression. We want to make sure they definitely have that family support. Chemotherapy. These are all kinds of different chemos that you may read about. The most important thing that I can really advise you guys to do, because I do know in HESI that they will ask you on certain drugs. I don't really like that because if you guys look at your book, there are a lot of chemo drugs, a lot. And I don't think that it's beneficial for me to try to test you and like make you memorize all those, which category all these medications fit into, because they all work kind of similarly, but in a way it can be very confusing. The most important thing about the chemo medications is their side effects. So what do we know about all chemo? What can it cause? Nausea, vomiting, loss of hair. So you think of those things because that's pretty traditional. Now, when you look in your book at that chart of all these different medications, the things that may stand out to you, like the alkylating agent here, not only do they cause a nausea, vomiting, and things like that, it can cause renal failure. If these patients do not stay hydrated, it can cause renal failure. It can also cause peripheral neuropathy, which we also kind of talk about because chemo causes peripheral neuropathy. The antimetabolites, these are kind of traditional uses for the bone marrow cancers or GI cancers. It can cause neutropenia. Does neutropenia kind of happen with a lot of different chemos? Yeah, because it can affect your white count. Because what did chemo, besides nausea, vomiting, what can chemo do? Because it's systemic, so it affects your entire system. So what else can it do to your normal blood count?
It lowers them.
Yeah, because it can't tell what's a cancer cell, what's normal. It just attacks them all. So you have bone marrow suppression with a lot of your chemos. Your anti-tumors, you may have cardiac and pulmonary toxicities. That kind of stands out. That's pretty important. These medications also are vesicants. What does that mean?
They tear up your veins.
Yeah. Yeah. So you need to really watch them when they are having this chemo done. And really, in home health, we used to not do chemo, but patients will actually hook themselves up, or they'll be hooked up and then they go home on chemo, and then we go out and we discontinue it. I don't know how much I really like that, just because of. But if it's 4 days of treatment, I just think it can be kind of unsafe because if the IV or the PICC line or something will come out, that can be kind of bad. And I don't know if a patient, maybe they teach that when they go home from chemo when they're discharged, but. Let's see. That's kind of the ones that really stand out. So those are things that I would think that if you're educating patients on, you can kind of say about the bone marrow suppression, the nausea, vomiting, and those things that kind of clump together with chemo. But then you want to know like those vesicants and then what can cause pulmonary or cardiac toxicities and so forth. Again, why is that on this slide? Oh, mine, not yours. Okay, so let's see, okay. So your chemo, before they ever start chemo, we will always do blood tests. So if we're doing CBCs, why do we want to do a CBC?
To know where their levels are prior.
Yeah, because are we going to hold it possibly?
Yes.
If their levels are too low, we are holding that because we don't want to destroy any more good cells because it can really affect the patient. Fevers, we want to check patients for fevers. If they have 100.4 fever, are we going to give chemo? No, we're not. So those are things that we need to know prior to administration. I'm just going to go down through here because I think what I wrote here, I put up here for you all. So wear proper PPE when administering medications. With an oral medication, can you or the patient touch it?
No.
You cannot. When they are going home, the best way to educate these patients is to pour it out maybe in their lid and then drink it. They cannot touch it. Okay, so those are things to educate the patient on. Let's see, do not crush or break pills. Obviously we have to educate them that they cannot crush or break them. When we are talking about side effects, extravasation is when that vesicant comes out of our veins and it destroys all of our good tissue and stuff. These patients may have to have plastic surgeries and stuff to fix it, some skin grafts. Bone marrow suppression, so again, if we see a reduction in red cells, white cells, platelets, then you need to think of what we are seeing in the patient, what signs and symptoms we see if they have that altered, okay? Anemia. When somebody's anemic, what do they often crave? Ice, right? Ice. So that's something that can tell you maybe they're a little anemic. Nausea, vomiting. We always, before they have their next chemo treatment, we want to ask, did you get sick? Because do we want them going home sicker than a dog? No. We want to be able to give them something like Zofran to help them not get so sick during chemo. Mucositis. This is where they get. Have you ever had a canker sore? Nobody's ever had canker sores?
Mm-hmm.
Jeez, man, when I eat spicy foods, I don't know spicy foods, I gotta watch it. But they have this all over their mouth. It's not just one, it's like all over their mouth. So it causes them not to be able to eat. So what things would you want to do? And there is really good reading about the stuff in your all's books. It tells you some management, because that is what nurses do. You're not going to sit there and just be like, tell them all about chemo and this and that. You're going to help them with their interventions on how to make them feel better, okay? So would I bring up some chips and salsa to a patient that has them? No. As much as they would probably want it, or I would want it, no, because it would really destroy their mouth. A good cup of orange juice, would that be great?
No.
No, because you really don't think about it. Even apple juice, the acidity is what burns their mouth. What about if they're brushing their teeth, right, with a soft toothbrush is what we recommend. But what if they're brushing their teeth and they're like, oh, I need to gargle, and they do get their stuff to gargle. What do we need to educate on?
No alcohol.
No alcohol, because it burns. So if we give somebody that, they're going to hate us for life. So again, you got to think of those processes and what you're doing as a nurse. Peripheral neuropathy. So chemo-induced peripheral neuropathy. That's what CIPN is. So again, we're educating our patients on neuropathy. I am not going to test you on this because when we go over sensory, that's when I'll go over this with you. Hair loss. A lot of people may go through like body image changes, things like that due to the hair loss, but we can educate them when the chemo stops usually within 6 months, starts growing back. So, and usually it's thicker. My mom's coworker had breast cancer, and when her hair grew back, she's like, one good thing about all my chemo and stuff is it made my hair grow thicker, and so now her hair is beautiful and thick and pretty.
Is that usually because the good cells are growing back at an alarming rate?
Yeah. And they're more healthy, so that's why.
Yeah.
Bladder toxicity can occur. I actually read in a new study about bladder toxicity with chemo and other things that now they're kind of doing like that hyperbaric chambers kind of with these patients, and it's kind of helping those things, but they're trying to dig in, do more studies on that. Neuro, have you ever heard of chemo brain? Okay. So when we were getting drywall in our house, we hadn't heard from our drywaller, and I told Nathan, I said, I think you need to call him. He's like, no, I don't want to bug him. And I said, I think you need to call him. We haven't heard from him. And I said, he may have forgotten. He's like, oh, no. And I said, he's on chemo. I said, they get chemo brain. So Nathan called him. He's like, hey, I just wanted to follow up. He's like, I'm so glad you called. I couldn't remember your name. I couldn't remember your phone number. And he says, that daggone chemo brain. And so that's what people go through is if they don't write it down, they're probably going to forget. And so you just kind of have to remind people of that. Psychosocial changes, again, hair loss, if they have a mastectomy, any changes like that, big surgical scars, we need to remember to respect those patients and help them. Treatments of chemo side effects. Well, dang, I already went over that. Okay. Never mind. Okay. So treatments. Radiation. So there are different types of radiation. You have teletherapy, brachytherapy. The biggest thing that's important about radiation is I want you to know how to educate your patients on how to care for their sight. Knowing the differences, teletherapy is a source delivered from outside the body. So if they go to a family member, like right after that, and they hug on them or whatever, they actually can, because it's not within them. So So this is the one that we really got to be careful of because they do emit that radiation. So children, pregnant women probably should be around that. So those are the differences between those two. Now with radiation, these are some things that can happen with radiation, some side effects. Skin hygiene is very important. There's a good chart in your book that explains some hygiene measures for these patients. Obviously, we want to give them a mild step. I wouldn't bring them some Victoria's Secrets or Bath and Body Works, really high scented smells because it can irritate them. We would kind of use like kind of that more mild soap. We obviously educate against hot tubs or really cold temperatures because that can also exacerbate negative effects on their skin. Scrubbing the areas, we all like to scrub in the shower. We can't do that. Like obviously we want to tell them to put it on because sometimes washcloths can be a little rough, right? So obviously we wouldn't like wash them down real hard, like they can just kind of wash real. Probably your hands is the best thing to wash. After you wash your hands and wash those areas, but not scrub them. They really need regular dental appointments. Loose clothes. If they have radiation to a site, do they want to probably wear tight fitted clothes, where especially jeans, where it's rubbing and it irritates it even more. Sunscreen has to be approved by the physician, because some sunscreens are not good with patients that have had radiation. Wait, not done yet. Monoclonal antibodies. So these medications, this is kind of a source that they use that combines, it's kind of like a combination therapy. It combines immunotherapy, which we'll see in a second, with targeted therapy, and we'll go over this here in a second. Immunotherapy in the 9th edition, it kind of goes into interleukins and interferons. Don't even remember that because the 10th edition wiped that out. Apparently it's not important for y'all. So don't really study that. What immunotherapy does is it takes when they take this medication, it actually boosts their immune system. It's like steroids for your immune system to be able to recognize the cancers and destroy them. Issue is there are some side effects like flu-like symptoms, fatigue, rash that can happen, so we have to monitor these patients while they're receiving this. Supportive therapy, whatever book you have, you need to find this in your book. There is charts or tables for this. When you review Neupogen, Epigen, these medications are really important because you don't only see it with chemo, but you may see it with patients with dialysis. But these help to give rise to our normal blood. So Epigen we see for our erythrocytes, so our red cells. So what they do is when you give a cancer patient these medications, they can actually tolerate high doses of chemo because if we're stimulating more and more regular blood cells, right, their normal blood cells, then when we're giving them high doses of chemo, it's not eliminating all of them because we're helping them build that those cells back up. Targeted therapy, block growth and spread of cancer, interfering with specific growth. So that monoclonal therapy, they kind of combine the targeted therapy with the immunotherapy to get rid of the cancer. Hormonal therapy, also known as endocrine therapy. So our hormones, like I said, tamoxifen can block that estrogen with cancers, with breast cancer or cancers that are estrogen related. So tamoxifen is great. There are other kinds that you don't really need to know that. You just need to see how much this can be too involved for you guys. Yes. So the biggest thing I want you guys to know about the chemotherapy and things like that is what you're doing for them, what you're monitoring as a nurse for. Okay. Side effects, things like that, as far as maybe the chemo specifics, the things that we would educate on. But other than that, like how they're working, things, I don't want you all digging that deep. again, this I'm not going to test on because the ninth edition doesn't really have that information. But on page 807 in the 10th edition, on page 807, that's where this nice readout is about stem cell transplant. The biggest thing to do is really just read about this before you're testing, but to also know that when people receive stem cells, when they receive those, are they able to utilize those stem cells right away? Like, are they good? Like, they get them, they're fine, they go about their business. What happens? Kind of takes time.
Talking about the stem cell, it wipes you out completely. You gotta be completely isolated. At least most people 30 days.
Yeah, usually 5 weeks. Yeah, 2 to 5 weeks usually is what they tell people. They have to wear masks. They have to be very cautious because they have no immune system.
And if you go visit anybody like that, you've gotta. It's almost like you're going into a clean room. You gotta be all.
Yeah, and that's also why we have neutropenic precautions in the hospital because we're not protecting ourselves, we're protecting the patient. So that's why we do that. So again, nausea, vomiting, fatigue, hair loss, all these things can occur. Monitor for infections with these patients, but just know that they're not good as soon as they get them. They have to wait until their body takes to it. Complications of cancer. So these are some of the things that we see because of cancer. So we're going to go into more in-depth talk here in a second. So I'm not going to read over these. You can read over them by yourself, but I want to get into the emergencies because this is stuff that you definitely want to know. So sepsis and DIC. I don't talk too much about DIC because you'll get that in the 4th semester because it's more critical care. But you need to know the process of you see it and you recognize it because that patient needs more medical help. So infection risk related to the treatment or disease process. Obviously, cancer patients, anybody on chemo or if they have cancer, especially leukemia and things like that, they're at a high risk of infection. We have to monitor for any low-grade fevers because we want to catch the stuff right away. Because if we don't, and they don't receive early treatment, then it can cause DIC. Okay, so what happens with DIC is patients begin to clot. They clot everywhere. You may even notice, like maybe if they're receiving fluids or something, and it backs up, you notice all these little clots, but they clot everywhere. Their clotting factors will be all abnormal, things like that. And in essence, once they continue to clot all this, what happens to our clotting factors? We clot a lot.
They're all used up.
They're all used up. So now they're reduced, and now we have bleeding. So that's where people are like, oh my gosh, so you have clotting and bleeding at the same time. With DIC, yes. So this is why you have to notice this, and it's really important because, this can kill a patient. But anyways, clotting can block blood vessels, and it can block blood flow to major organs. All this stuff happens. That's why it's very quick when it happens. So we got to get treatment right away. What is it?
I was gonna say, even for a normal person, sepsis is sneaky.
Oh yeah. Yeah,
I mean,
they can come up on a
I know
person quick.
people that were healthy and then were dead in a week because they didn't catch their sepsis.
Mm-hmm. Yeah, and I've seen it a lot in the hospital where, maybe somebody's blood pressure is getting lower and lower and trending lower and lower and lower. We should recognize these things, but it's when unrecognized. And so then we can have this happen. When I was in nursing school, I had just learned about this in my critical care class, and I went to an ICU for my rotation, and I got report, and it made me start thinking about DIC. So I went and looked at the clotting factors, and I was like, oh my gosh, and I talked to my, we had partners in our nursing program, so I was like, told her, DIC. And so she was like, oh, let's go tell our nursing instructor. I was like, I ain't telling her because she made it stupid if it's wrong. And so once she told her, and she was like, Cassie's going to figure it out. And she's like, actually, they're already going to start treatment for DIC. So the treatment is kind of replacing these clotting factors, plus trying to give them some blood because now they're bleeding. But again, you're going to learn more of that in the 4th semester.
You see a lot of that in palliative care well, their disease process has led them there, but they usually die because they're septic.
Oh, yeah, yeah. And their body's just shut down.
Yeah.
I mean,
Yeah.
because all the clotting stuff has, the blood can't get to it. Okay, SIADH. What is ADH? Going back to your physiology class again. ADH. You have to know about ADH in order to understand this process. Antidiuretic hormone. So what SI stands for is syndrome of inappropriate ADH. So syndrome of inappropriate. So if we have an antidiuretic hormone, and now our body is kind of putting too much out, what's that going to do? Too much fluid? Too much fluid. So what does that do to our sodium level? If we have too much fluid, if I had, before COVID, I would have done this, and then COVID happened, and now I wouldn't. But I would have brought a huge bowl in here, okay, of water. Or actually, a bowl, and I would have put a little bit of water and some salt in it. And somebody would have drank it and told me it tastes like the ocean, probably. Then I would have filled that whole bowl up with water, and then you would have taken a drink again. Did you taste it? The salt? No. So that's what our body does. Our body, if we have too much fluid, it kind of, the sodium levels reduce. Okay, so you got to remember that. What happens when our sodium levels start reducing? Then you have your mild symptoms that you should recognize. You have severe symptoms because when it starts turning into confusion and stuff like that, I mean, when it gets to the point of less than 115, your sodium level, so you need to know your normal sodium levels. If it is below 115, sometimes these patients are in coma. And I mean, they can die from this. So do we need to watch our sodium levels? Of course, with these patients. So you're going to see CBCs, BNPs on these patients all the time because this can happen. Management. If we have too much fluid because of, our antidiuretic hormone, then we're going to obviously fluid restrict these patients. So these are going to be the people that you have that note on your door about the fluid. We're going to do close monitoring, oral rinses because they're obviously going to get really dehydrated probably. We want to watch any type of weight gain because that means these patients really should be hospitalized. You may see this is very, I don't know, you may or may not, but they may do hypertonic fluid. But again, they are going to really monitor for any fluid overload because they want that sodium. So these people are the ones that we can give a lot of sodium to, right? We're not educating them on heart issues with high sodium levels. We're trying to get their sodium level high. And then we monitor for fluid overload. What are things that happen with fluid overload? Breathing problems. What? Yeah. So you're monitoring for fluid overload. So those are things that you definitely, if you don't remember what signs, symptoms of monitoring for fluid overload is, you need to definitely want to look that up. Review that. Spinal cord compression. So this is really associated with cancers that are located near what?
The spinal
Your
cord.
spine, your spinal cord. So these tumors and things, what happens is it compresses, and anytime we see any of these symptoms, now again, these signs and symptoms vary because if it's breast cancer, it's kind of higher up. So we may see some like hands, tingling, and then it may go down their body, right? But as far as like if their tumor is lower near their spine, then we may see the urinary retention and things like that, and maybe their legs and feet are tingling. So again, but any of these things, this needs to be a red alert. This is something that they have to know. These patients need to be educated on because a lot of patients that, even my family members that I've tried to talk to about this stuff, they kind of brush it off. I'm fine. It's just letting my arms sleep. So we've got to educate about this because these patients need to be in. They need to get radiation and steroids to alleviate that compression. So these are all emergencies. So these are all things that are important because they're emergencies, and we could all recognize these things. Hypercalcemia. So again, when bone destruction occurs, it releases that calcium into our blood. And that's why we see those high levels of calcium. But where bone destruction, it releases calcium into our blood, and that's why we see those increased levels, because it's not in our bone, it's in our blood. Side effects, here's some different side effects that you guys can look over about calcium. You probably remember that from second semester. Management, so these patients will receive some normal saline, loop diuretics. Why do we want loop diuretics, but we avoid the thiazide? Well, they actually hold on to calcium, the thiazides do. So we don't want to get rid of it. We don't want to hold on to it. Then these other medications, dialysis can help because it can remove it, but the bisphosphonates can help because it actually helps to take that calcium to the bone, move it. Supervening cava syndrome. There's a great picture in your all's book in the 9th and 10th edition. And it almost looks like, as everybody was saying, well, you said that was breast cancer. And I said, well, I did say it was breast cancer, but on the affected side. This picture is where this person has engorged veins that go from like up their chest, up their neck. And if you are that engorged, you're probably going to be one, in a lot of pain, but two, you can't breathe because everything's obstructed. So they have edema in the face, the engorged blood vessels. It tightens around their collar so they feel like they're being strangled almost. Yes. These patients, right away, they'll obviously do some imaging maybe, but they're going to, if they know it's a clot, they're going to give medication to break the clot, or they'll give high-dose radiation if it's a tumor, and then chemo to control it. They rarely ever do surgery for this.
What's the percentage of outcome?
I don't know. It doesn't really say about that. I would say not good. Because, yeah, almost. Yeah. Because there's not a lot, unless they can get to it right away. But a lot of times, if you're talking about a tumor and trying to get radiation to that tumor to shrink it, and if you know what I mean, if it's a tumor now clot, it probably wouldn't be as bad because we could get that on board pretty quick, but radiation and chemo. Because chemo you got to use to control it. But again, that's why early recognition is the best. If we wait till, if you look at that book, it looks bad.
Isn't that syndrome normally how that comes with late signs? They usually don't. They're not gonna usually catch it early.
Right. But I think the biggest thing is if they start noticing engorgement, but once it gets up to their collar where their eyes are bulging and everything because they are unconscious is what is bad for these patients. Now this tumor lysis syndrome is probably the only good emergency. Okay, it actually means the treatment is working. It's because the chemo is such a high dose chemo and a pretty hardcore chemo that it is working, so that's great, right? But the effects of it aren't so good on the patient. So we see these patients have increased potassium, and your uric acid levels are high. And obviously, if we have high potassium levels, what can that do? What does that have effect on? It's going to affect their heart. So these patients definitely are going to be on monitor. We see it a lot with the high-grade cancers because high-grade cancers they need what type of chemo? They need pretty high-dose chemo. So that's why we see it with these cancers. Allopurinol treats what? What is it? Uric acid levels. It helps with uric acid. And then we have IV infusion of insulin with glucose for those potassium levels. K-exolate we can also do for these patients if their potassium level, maybe they're not completely at tumor lysis syndrome, but they're kind of, if we see their potassium trending up, they may be like something like K-exolate to spell that potassium. To prevent this syndrome, we tell patients that they have to drink large amounts of fluid before they have their chemo. Pretty sure, I can't remember what's in your all's book, but I'm pretty sure it says 3,000 to 5,000 mLs. So they do it usually the day before chemo, the day of chemo than 3 days after chemo. All of that fluid, because it helps them to do what? Kind of excrete all that, right? Get it out of our body. So that's why they really have to stay hydrated. So what I'm going to do is, y'all can go to the bathroom if you need to, but what I would like to do, you guys are going to be on teams. Oh, this side is very low on people. That's okay. So what you do with your team is, I would advise you guys to split up studying this stuff. Okay, you don't really need to study like my tissue here, or the duplication process, mitosis, the normal cell. I'll ask you questions, but you don't really need to know for the test. Neoplasm. I may ask you questions. But from like your primary, secondary cancers and one, I would maybe split that. You don't have to if you don't want to. You can just wing it and see how good you guys are. But it's just to kind of recall the information I gave you. I think it's the best way to study is me go over it and then you all teach me, because then you remember. I don't know what it is, but this game has seemed to really help people in the past, so I continue to do it. Except for when COVID happened. But okay, we're back to class. So y'all can either study by yourselves or do something and start it probably at 10:05, so probably about 10:15, 10:20. I gotta go get my buzzer.